Good evening, everyone, and I hope everyone can hear me. It's Albert Yee here, and Michael and I are co-directors of the University of Toronto Department of Surgery Spine program. And so this is our special SpineFEST this year as a virtual platform, and sort of looking at the participant numbers increasing, and I think we've already achieved a record in terms of individuals that are participating. So I bring greetings from Toronto. I have my virtual screen of Toronto behind us for those that are not able to be here in person. But Michael and I would like to take a few minutes ahead of the formal meeting just to share some time and to honor and recognize a colleague of ours, Dr. Todd Mainprize, who suddenly and tragically passed away this past week. Terry, I'm just checking that you've shared the forward slide button. Thank you. Todd was a dear friend and colleague to many of us at the University of Toronto, and worked closely with those of us, myself included, at Sunnybrook Hospital. He was a tremendously gifted neurosurgeon and a division chief at Sunnybrook. He, over many years, really engaged enthusiastically in all of his professional endeavors, and it was really great to witness his growth over many years. He always had a very infectious smile, was very energetic and passionate, very caring for his patients. And so Michael and I just have asked one of our colleagues, Dr. Jeff Wilson, down at St. Michael's Hospital downtown, to say a few words about Todd as an individual who's worked very closely with Todd. So I just wanted to thank you, Jeff, for taking the time to do this during these difficult times. I will turn the virtual microphone over to you at this time. So Terry, if we can have the next slide, please.
Thanks a lot. Albert, can you hear me okay?
Yes, I can.
Yeah, thanks very much for the introduction. And you know, it's nice, I think, for all of us to be here together, even though we can't be together in person, you know, during times of strife like this. It's nice that we can at least gather virtually to share some of our thoughts about, you know, this great man that was Todd Mainprize. And, you know, as you mentioned, he passed away last week, just 3 weeks before his 50th birthday. And I think, you know, on a professional level, this is obviously a big loss to the neurosurgical community in Toronto and in Canada. But I think at a personal level, this is really a tragedy without precedent that many of us are still grappling with and having a hard time dealing with, frankly. But, you know, Todd is an amazing person, and he was truly a superstar everywhere he went in his life. He grew up in a small farming town in southwest Saskatchewan called Outlook. And he excelled at pretty much everything he did as a youngster. And he went on to medical school at the University of Saskatchewan, where he graduated in 1996. And was mentioning this earlier or last week, some others, that I also went to that medical school and graduated about 10 years after Todd. And he lives on in infamy because you know, not only did he win the gold medal, which was, you know, awarded to the medical student with the highest grade point average, but also he won the silver medal, which was awarded to the person who was the best clinical doctor and humanitarian. You know, he had an interest in neuroscience and neurosurgery, and he came to the University of Toronto to do his residency. And right off the bat, he quickly started punching above his weight class. He was kind of known as the human encyclopedia, not only for neurosurgery, but for most things in life. Really a smart person, incredibly quick-witted, very intelligent. And this was counterbalanced, albeit with, you know, a lust for life. He liked to get out on Friday and Saturday nights, apparently with his buddies, and drink some beer when he wasn't, you know, studying or doing neurosurgery. He also did some great neuro-oncology related research in the lab of Jim Rutka as a resident, and I think this instilled in him a lifelong passion for this branch of neurosurgery, and he continued that passion throughout his career and did research in that realm. After residency, he started as a neurosurgeon at Sunnybrook, and he quickly ascended to become the division head of neurosurgery at Sunnybrook. I think he was, you know, so well known and so regarded for multiple things. I think first and foremost, patient care. Todd made each one of his patients feel like they were the most important person in his life. He routinely came in and rounded on the weekends and times when he wasn't on call, even when he didn't need to be there, just to make his patients feel valued and special and that they were well taken care of. He was a fantastic surgeon. While many of us, including myself, kind of retreat to one subspecialty within neurosurgery, he did most every part of neurosurgery, all subspecialties, and he did it to an exceedingly high quality and standard of care. And for that, he truly was a master surgeon, to which many of us aspire to be like. He was a fantastic educator. He had a way of touching residents and getting them involved with you know, thinking about things in new ways and just broadening their horizons, expanding their scope of understanding. He won all the teaching awards and was always recognized as, you know, one of the best educators in our program. But in spite of these things, I think what he'll be best known for is really his personal qualities. He really made people feel like they mattered, not only his colleagues and friends, but people who were seemingly insignificant, like the people who swept the floor or the person that was, you know, serving him coffee at Tim Hortons. He had a way of making people feel important. And I know in my own life, in times of strife or after complications in the operating room, personal stuff, he would always make me feel better just by a brief chat or having a beer at the end of a day. The world always looked a bit brighter after speaking to Todd. I would say that in spite of all this, though, that, you know, his family, in spite of all these accolades, his family was always, I think, at the top of his mind, fore of his mind. And I think he considered this his best accomplishment, his family, and he loved them dearly. I know that. Our hearts go out to his wife, Susan, and his children, Graham, Thomas, and Victoria. You know, he always beamed with fatherly pride when speaking about his kids or recounting one of the recent trips to the lake in Saskatchewan or one of the more elaborate trips to Vietnam to visit Susan's family or abroad to Europe in more recent years. You know, in closing, I'd just like to say that, you know, the loss of Todd, I think, really leaves a tremendous hole in many of our hearts that will not soon heal, but truly he will live on in the way of all the people and the patients that he's touched and in the memories and in the hearts of those who really love him so much. And so I say to my friend, rest in peace, and you will not soon be forgotten.
Thank you so much, Jeff. And you know, I think many of us share similar sentiments. And you know, as difficult a time as it is, I think we do think of Susan, of his children. I know the family have put out a keepsake link where folks can provide some fond memories for of Todd and I think for his children when they grow up a little bit more. So at this time, I appreciate the group's patience as we take a moment of respect and a moment of silence in honor of Todd. So thank you everyone for that respect. I will gradually segue to our SpineFEST program. And I think recognizing Todd as a real phenomenal teacher and educator, I think he would have liked to see us carry on with this type of program, which is very much geared around our trainees and our broader spine community. So as we start our SpineFEST program for this year, recognizing this is a slightly newer format for us, we'll be taking questions and answers through the Q&A icon that you should have access to within your Zoom. The link below, as well as the barcode, has the full details of our program and agenda for this evening. Terry, can I go on to the next slide? And just thank you. Not seem to get the controls. Okay. Many of those logging in have been part of the spine program community for many years, but we have had a record number of registrants this year, and I know we have a few distinguished guests and colleagues with us today, not only around the GTA and Ontario region, but also nationally, as well as many of our international colleagues, alumni, as part of this virtual platform. And so our program really has been one of looking at opportunities for collaboration and integration, bringing together neurosurgery and orthopedic surgery within the Department of Surgery, to advance collaboration and efforts with various disciplines and a variety of stakeholders with common interest in spine health and spine care. Next slide. I just want to acknowledge and thank Ms. Nadia Jabber, our program coordinator, for all her efforts throughout the year in organizing us for our academic calendar of events, and she has been a central pillar of our program. So thank you so much, Nadia, for all your expertise, the tremendous graphics and organization of our venue for today, as always. Next slide, please. Special acknowledgements to our faculty from around the city, members of the program council, education, as well as research committee. I appreciate all the support over many years. Next slide, please. As mentioned, a lot of our efforts are framed around really educating and training the next generation of clinicians. And apart from our residency program, both I think our residency as well as fellowship programs are the largest programs in the country, and at the clinical fellowship a year, we typically have and train about 13 to 15 clinical fellows spanned around the various hospitals in Toronto. And typically each year, about half of our fellows come from Canadian trained residency programs, either in neurosurgery or orthopedic surgery, and about half of our fellows are from international backgrounds. Next slide. Recently, even throughout this COVID pandemic, we've maintained focus really on education and teaching, and looking for innovative ways of how we can deliver content. And this past week, Dr. Stephen Lewis, one of our colleagues at the Toronto Western Hospital, also put on a sort of a hybrid course as it relates to surgical skills at the Mount Sinai's surgical facilities, which was actually one of the first educational venues to be conducted since the time of the lockdown of the COVID situation, and it's more recent reopening. So I just want to acknowledge Dr. Lewis and the other faculty from around the city that have come together to help support ongoing educational efforts. Perhaps the next slide, and at the stage, I'll turn the virtual podium over to my colleague, Michael.
You're muted, Dr. Fehlings.
Can you hear me now? Good, okay. Thank you, Albert, and big thanks to Nadia Jabber as well for organizing this virtual symposium, and a shout out also to Terry and his group for assisting us. And of course, we're also doing this under somewhat difficult circumstances with the passing of a dear a colleague, but I know that that Todd would have wanted us to continue in the spirit of promoting collegiality and reaching out to the trainees. So an important part of the University of Toronto the Spine program, which links the clinical and research faculty and the trainees across the city, is also research training. We have 35 program faculty members with a research focus on spine. There are many multi-center clinical trials. There's basic research, translational research, a number of national and international registries that we either lead or participate in. And this is reflected in a very strong publication track record, with on average nearly one publication about every 2 days. So really quite a significant degree of productivity. So SpineFEST 2020, this was initiated a number of years ago actually by Albert Yee, and then when Albert and I were asked to begin the University of Toronto Spine program, we amalgamated many of the activities that were going on. The annual lectureship is named in honor of Professor Charles Tator, Professor Hamilton Hall, and we'll hear some words from them, and we're honored to have Professor Marcus Stoodley from Australia as this year's Tator-Hall visiting lecturer. So this is brings us to the current event, and again we're very grateful to Marcus Stoodley for graciously participating in this virtual symposium. Marcus, we'd hope to have you here in person, and we hope to do that at some point in the near future. So we've decided to split what normally would be a full day event into 2 evening events, which will be this evening and tomorrow evening. And we anticipated that there would be a clinical ramp up which would be occurring, and so we tried to avoid conflict during the usual workday. So we hope that this works well and is respectful of people's time commitments. We also have an e-poster set of presentations through a web-based software program called VoiceThreads, and I would encourage you to have a look at the e-posters, which are excellent. In addition to the SpineFEST visiting professorship, we have a very active academic calendar, which is reflected in this slide. So we have several visiting professorships, and in fact, we've had over 40 visiting professors in the past 12 years with a number of named symposia. We have an active journal club program, and we've been able to transition this to a virtual format. And in fact, we had a webinar on COVID-19 during the initial few weeks of the COVID pandemic, and this was actually quite well received. I should point out that one of the speakers, a former fellow from the University of Toronto Spine Program, is from Wuhan, and he himself had COVID and fortunately survived that. We also have taken advantage of the current restrictions imposed by COVID to open up our educational offerings at the various teaching hospitals. And so all of our rounds, apart from the quality assurance rounds, are now open to the faculty and trainees from Toronto. And in fact, we've used this as an opportunity to invite alumni. And we've had a number of courses. Albert's mentioned Steve Lewis's outstanding hands-on course, which was done respectful of all of the appropriate precautions, and it was a big success. And we have a boot camp that we do to teach technical skills, as well as various skills related to spinal cord injury assessment and management. And we also have a Royal College mock oral that we do to help the senior residents prepare for their examinations. This graphic just gives you a sense of the global impact. We've trained over 200 fellows over the past 20 years, and literally our program does touch all corners of the world, as depicted in this slide. And part of the point of SpineFEST, and this will be the main focus of tomorrow evening, is to express our gratitude and appreciation for the fellows. And this pictorial just shows the Spine Fellows from 2019-2020 who will be graduating, and we'll be recognizing them tomorrow evening. We have had quite a remarkable registration. About 500 people have registered. And this just shows the registration by a continent, which I think is, again, a reflection of the international impact of the University of Toronto Spine Program. I also want to express our gratitude to the Department of Surgery at the University of Toronto. Jim Rutka has been extremely supportive, as has been the divisions of neurosurgery and orthopedic surgery. And we also are very grateful for the support that we receive from industry in the form of educational grants to support our work. And we live under extraordinary times right now, and I think that this saying from Alain de Botton is particularly poignant. And I'll just let you read this this statement. So at this point, I'd like to kindly ask Professor James Rutka, our department chair, and Dean Richard Hegley, representing research in the Faculty of Medicine, to bring greetings from the University of Toronto.
Great, thanks, Michael. Maybe it's okay, I'll go first. And I just want to say thanks to you and also to Albert for organizing SpineFEST again this year under these circumstances that were mentioned. Thank you also for recognizing Todd Mainprize at the beginning of the SpineFEST proceedings. Those of us who knew Todd, and many are on the line, are really shaken to the core when we consider what has transpired. But just as everyone has mentioned, I think Todd would really want us to carry on today as we are doing in his name and memory. And thanks to Jeff Wilson for a very fitting tribute about Todd. So academic events like SpineFEST are mission critical. We didn't know how we would embark on these, especially during a pandemic like COVID-19. But Michael and I worked together to put Galley Day forward, and I think it was a marvelous success. We heard about the spine course that you've just undertaken with Steve Lewis, which was a brilliant idea, and now SpineFEST. So nothing's holding us back when it comes to our academic offerings. and programs for our residents and fellows. And as mentioned, this is extremely important for our educational mission. So the Tator-Hall lecture, as was brought to everyone's attention, is a highlight, and this year is no different. It's a real who's who of who's doing amazing spine surgery across the world. And it's my great pleasure to see Marcus Stoodley on the line. I met Marcus first when he was a fellow at Stanford University many years ago. And Marcus, if I'm not mistaken, it's around 7:30 in the morning in Sydney, Sydney time, if that's where you are right now. And we look forward to your presentation on the craniovertebral junction and EDS, a really important topic. And I think several of the registrants on the line today are actually members of the EDS community. So it's really important that we're having this discussion today. So I'll stop there, Michael, and just give wholehearted congratulations to the entire spine program team. So you and Albert and the Spine Program Council and Committee for putting this together. We bring you best wishes for our great SpineFEST this year, 2020, from the Department of Surgery. Thanks.
So thank you, excellent remarks, Jim. And on behalf of the Faculty of Medicine at the University of Toronto, I also want to welcome everyone to the unusual circumstances of this year's SpineFEST. I think it shows the ability for adaptation, which is so necessary for all of us to continue to be able to thrive under the circumstances that we are in and to be able to make the best of the hands that we've been dealt. In terms of the spine program and how it fits into the greater Faculty of Medicine schema, it's a stellar exemplar of what we are trying to do as a university within our complex system here in Toronto. So, you know, we live in a system where we have very powerful autonomous hospitals, which are very proud and very, shall we say, well positioned for competitive type attitudes. And when you saw the opening slides of finding collaboration within that highly competitive space, it does lead to a successful implementation of the concept of what I call co-opetition. And it's the co-opetition between the institutions where the University of Toronto is a glue by virtue of all of us having University of Toronto faculty appointments, which allows synergies and punching above each individual place's weight to have the maximal potential impact. And again, if you show the global reach that the spine program has and continues to grow, it's a very, very impressive example of what we need to be doing more of in the system here that we have in Toronto. So on a personal note, I will be leaving my post as a Vice Dean of Research and Innovation at the end of the month. And I have the countdown clock actively ticking on the corner of my computer monitor. And I would say it's been an absolute pleasure to work with Michael and with Albert over the years, and in which I've been Vice Dean. I've even seen the evolution and progression of SpineFEST over my time as Vice Dean, as it has continued to grow, develop, and continue to thrive and find new ways to find and make a greater impact. So congratulations to SpineFEST, congratulations to Michael and Albert for leading such a fantastic program. And it's a great example and a great role model for the rest of us in our Toronto system. So I'm wishing you, under the circumstances, the best possible SpineFEST you can do. And I know that it will be memorable and have high impact. And thank you once again. Thank you.
Thank you so much, Jim and Richard. We really appreciate those kind remarks. And in particular, we're very appreciative of the support that we receive from the university. I earlier alluded to the leadership that Professors Charles Tator and Hamilton Hall have shown, and really as pioneers who have built much of academic spine surgery in Toronto. And the lectureship, which Professor Stoodley has this year, is referred to as the Tator-Hall lectureship. And at this point, Doctors Tator and Hall will present their greetings through a video clip. So if Terry, if we could please play the video clip.
On behalf of Dr. Hamilton Hall and myself, we are very pleased to welcome you to the 12th SpineFEST at the University of Toronto. Very pleased to welcome you as well to the Tator-Hall lectureship at SpineFEST, which this year is about number 12, I believe. This lectureship has had wonderful academic and practicing stars in the spine world, both in the orthopedic spine world and in the neurosurgery spine world. And Hamilton Hall and myself are honored to be associated with this lectureship. We are grateful to Albert Yee and to Michael Fehlings for keeping it alive so many years. It's our pleasure to be involved and our pleasure to welcome another star, Dr. Marcus Stoodley from Australia, who is an expert on a very difficult part of spine and neuro and ortho work, the work on the cranio-vertebral junction, where Chiari malformations occur with or without Syringomyelia. This has always been a very fascinating part of spine work, and Dr. Stoodley is of international fame for his research into this condition. Welcome to Dr. Marcus Stoodley. Thank you very much. And over to you, Dr. Hall.
As usual, Charles, for those that have been to SpineFEST in person, and this year, obviously, we are not there in person, everyone knows that I stand behind you and say very little. So I will this time stand beside you on the screen and say very little, except to say that I think it's impressive how they've managed to transition this program from a live program to a virtual program. I think it's going to be very interesting how the progression is recorded, is taken, and how the speakers are going to have a chance to interact visually and virtually rather than in person with the audience. Charles, you and I both have enjoyed our mutual association. As we both know, we go back a very long way, much further back than either one of us will ever admit, when you were my resident and I was your assistant back in the good old days at the Toronto Western. But since then, we've both come a good distance. And I think it's interesting that this time we're doing something that neither of us have ever done before, which is to present virtually. I hope the audience will enjoy it as much as you and I have enjoyed preparing for this. Nadia, thank you very much for getting us on screen. And I think it's time to start the meeting.
Thank you very much. And I just wanted to acknowledge that we do have Professors Tator and Hall here in person, and just a shout out to both of them, and thank you for your ongoing support and inspiration. So at this stage, it gives me great pleasure to introduce our keynote speaker, our 2020 Tator-Hall lecturer, Professor Marcus Stoodley. And Marcus is a dear friend. He is an exemplar as a clinician scientist in cerebrovascular neurosurgery in the cranio-vertebral junction and the treatment of Syringomyelia and Chiari malformation. Marcus is the head of neuroscience at Macquarie University Hospital, which is an example of a leading institution in Australia that combines excellence in clinical care with the integration with the university, and allows clinician scientists such as Dr. Stoodley to flourish. Professor Stoodley completed his neurosurgical training in Australia, and as Jim Rutke had mentioned, then went to the United States to undertake further subspecialty training at Stanford University and at the University of Chicago. At Macquarie University, Dr. Stoodley has a very active clinical practice which focuses on complex cerebrovascular disorders as well as complex disorders of the Cranio-vertebral junction and Syringomyelia. And this is reflected in his translational research program, which focuses on CSF disorders. And he's been extremely productive in terms of peer-reviewed grant publications with over 150 publications. He brings in a considerable amount of peer-reviewed research funding, and he's won a number of prestigious awards, including the John Mitchell Crouch Fellowship, which is the premier research award from the Royal Australian College of Surgeons. And Marcus, we're particularly grateful that you've graciously agreed to navigate the turbulence of the COVID pandemic and to present your lectures to us virtually. And would now invite you to present your keynote address on the management of Syringomyelia, impact of new understanding of CSF physiology.
Thanks, Michael and Albert, and for the invitation to come to Toronto. I'm obviously disappointed I can't be there in person, but you'll be pleased to know I prepared for this by sitting in a small seat for a couple of days and not getting any sleep, pretending I was on a plane. But here we are. It's the new way. I do look forward to catching up at a future date. I'll apologise in advance that this talk contains no implanted metalware, which I'm sure would be the flavour of most of the talks in this seminar. I'll start with, I have no disclosures other than that I live in this country down here, which is faring pretty well in the COVID environment. I come to work every day in this hospital, which has that sort of weather every day, just like Toronto, I'm sure, and this is how we celebrate the graduation for our residents and fellows. So I'm going to talk today about Syringomyelia. I'll talk a bit about the theories of pathogenesis, some background of CSF physiology, and how that impacts on how we manage Syringomyelia here at the moment. Syringomyelia is obviously, it's not a disease in itself. It's something that occurs in conjunction with many other conditions, and divided here into spinal, Cranio-Cervical junction abnormalities. But really it boils down to the vast majority of cases falling into these categories of either Cranio-Cervical junction, spinal cord injury, arachnoiditis, or where we don't know the cause. And often I tend to group spinal cord injury and arachnoid pathology together because I think they share very similar aspects. If you look at textbook descriptions of Syringomyelia, they'll often have this kind of wording, implying that this is a passive process with loss of tissue and just a cavity forming. And you'll see this kind of pathology picture that gives that impression. But all of us as neurosurgeons know that Syringomyelia is not like that. It's a much more dynamic and enlarging cystic cavity, not a passive collection of fluid and tissue loss. As this intraoperative video demonstrates, the CSF pressure inside a syrinx cavity can often be quite high. This is all syrinx fluid coming out of the spinal cord in a post-traumatic syrinx case. So it's not a passive process. We know that the pathology comes in various flavors. There's ones that communicate directly with the fourth ventricle. That tends to be the spina bifida cases. Ones where the syrinx occupies the central canal but doesn't communicate directly with the fourth ventricle. That's often the Chiari malformation cases. And those where the syrinx commences outside of the central canal, and that's the typical situation for post-traumatic and arachnoiditis cases. So for the non-communicating canalicular syrinx cases, the syrinx is generally lined by ependymal cells and there's no actual tissue damage. And so patients with this type of syrinx will generally be asymptomatic unless the syrinx ruptures through that ependymal lining and starts to damage the cord tissue. And that's where the clinical features will arise. For patients with extracanalicular syrinx cavities, the syrinx, by commencing outside of the central canal, will always cause tissue damage and will generally be symptomatic, as in this arachnoiditis case and in post-traumatic cases. We're generally taught in medical school, I think, that a syrinx occupies the center of the cord and interrupts the crossing spinothalamic fibers, and that's what gives this typical clinical presentation with the cape-like sensory loss. So that's not actually the case. As I said, it's when the syrinx ruptures through the central canal lining and causes damage, typically in the dorsal horn, that's the location where the spinothalamic tract is interrupted. It's not the central part of the cord. So the big question really is, how does a syrinx form? And there are various theories that I've grouped here into hydrodynamic and other theories. You're probably all familiar with the original theories of Gardner, who suggested that CSF was forced in what he called a water hammer type of function, with CSF being forced into the central canal, and then a Chiari malformation would plug that opening and prevent CSF from coming back out of the central canal. And Bernard Williams had a slightly different slant on it, where he said if you coughed, you would force CSF into the head. The Chiari malformation would then plug the cranio-cervical junction, and CSF would be then forced into the central canal. The problem with those theories is that the distance between the fourth ventricle and the syrinx is often very long, and it's just not physically possible for CSF to be forced down a very tiny central canal to form that sort of syrinx. Having said that, we recognize now that there are sometimes cases where the syrinx is close to the fourth ventricle and is communicating, and I'll talk about that later. More recently, there have been suggestions that the CSF enters the cord through the cord surface. In the 1970s, Ball and Dayan suggested that this occurred with coughing and sneezing that increased pressure in the subarachnoid space. And more recently, Oldfield, Heiss, and others have suggested that the Chiari malformation acts like a piston, forcing CSF into the spinal canal, increasing the pressure in the subarachnoid space, and forcing CSF through the cord surface into the syrinx cavity. The problem with those theories is that it can't be an external pressure that enlarges a syrinx cavity on the inside of the cord. So for a syrinx cavity to get bigger, which it must do at some point, the pressure inside it must exceed the pressure in the cord and the pressure in the subarachnoid space. And so it can't possibly be just pressure on the outside that is doing that. And in addition, if you treat a syrinx with a shunt, as I've done here, if that theory was correct, the syrinx should get worse because the CSF has a greater access to the syrinx cavity. Then there are theories suggesting that the problem is an obstruction of CSF outflow, that the compression across the cranio-cervical junction impedes CSF flowing out through the central canal or through venous absorption, or suggestions that the CSF velocity in the subarachnoid space causes a Venturi effect, and that causes what I suppose might be considered a passive enlargement of fluid within the spinal cord, with complex suggestions of how that might occur in spinal cord injury. You might think that all of these theories rely on some sort of abnormality in the subarachnoid space, but there are cases such as this with cord tethering where there's absolutely no abnormality in the subarachnoid space, and yet there's a large syrinx. And of course, there are cases where we don't know what the underlying association is. We think there may be arachnoid pathology here, but we can't see it. And so the underlying cause of that type of syrinx is really not clear. So I think it's fair to say that the pathogenesis is unknown, and there's no theory that explains all the types of syrinx that we see, and nothing, of course, that explains how you might get a higher pressure inside the cord than in the surrounding subarachnoid space, if we assume that the CSF comes from that subarachnoid space CSF. Now, it wouldn't really matter if we could manage these problems with great success, even if we didn't understand how it happened. But of course, with Chiari-related Syringomyelia, there's a very highly varied technique in surgical management, and what I would consider a high published rate of persistent problems with syrinx. With post-traumatic syringomyelia and arachnoiditis-related syrinx, there's an unsatisfactory surgical outcome with the generally used techniques of arachnolysis or shunt. And there are no large series to guide us for idiopathic syringomyelia, but I think in general the experience would be that the clinical results are not particularly favourable. So I think it's clear we do need to understand this better, and we could start that by looking at CSF physiology in general. And of course, we all understand the basic concept that CSF is produced in the choroid plexus, circulates through the ventricles into the subarachnoid space, and absorbed in the arachnoid granulations or arachnoid villi into the venous sinuses. It turns out that this is a very simplistic view of CSF physiology. A better way to think of it is that CSF is produced everywhere in the central nervous system and is absorbed everywhere in the central nervous system. And it's probably better to consider it conceptually like this diagram on the right, where the blood-brain barrier is around these vessels, and CSF is formed from the blood into the interstitial fluid and CSF, but there is no barrier between those two fluid compartments. And so it's best to consider, I think, all of the fluid in the parenchyma and in the CSF in the central nervous system as one single compartment, bounded on one side by the blood-brain barrier, but importantly, to not forget the other side of that barrier, which is the tight junctions of the arachnoid cells that line the dura. And that CSF is absorbed from those fluid compartments everywhere. It's absorbed into the blood vessels, it's absorbed into the venous sinuses through the arachnoid villi, but that's a small component of absorption. And there's evidence now increasing to suggest that a significant component of CSF is absorbed fairly clearly into the lymphatic system. So it's complex, much more so than our generally accepted view. We've focused a lot on, in my research, on CSF flow in and out of the spinal cord, and that came about from this evidence in the 1980s that CSF penetrates the brain through perivascular spaces, and that penetration depends on arterial pulsations. There's been a lot of work done on the ultrastructure of perivascular spaces, which impacts on this. And you're probably aware of the more recent concept that's been called the glymphatic system, where in the brain it's suggested that CSF enters the brain tissue through arterial perivascular spaces, washes through the brain tissue through entering through aquaporin 4 channels, and then goes out around venous perivascular spaces, acting like what they call here a garbage truck, but washing out large molecules from the extracellular space. So we asked the question, in the spine, could this be the way that CSF enters the spinal cord? And in particular, for the different types of syringomyelia, would this be the pathway of CSF entry? And so the first work that I did in this area was to look at CSF flow in the spine. And indeed, we demonstrated that CSF does flow into the spinal cord through perivascular spaces. But it's quite different to the brain, of course, because the central canal is here. And we showed that CSF goes from perivascular spaces directly into the central canal. And that is a very rapid circulation. It depends on arterial pulsations. This was experiments that we did in sheep, because we can manipulate the blood pressure without changing the mean blood pressure, and showed that that penetration does not occur if you dampen pulsations but keep the blood pressure the same. So we've got this concept then that there is a normal flow of CSF going into the spinal cord all the time, depending on arterial pulsations. But what we didn't know was what is the effect of respiration and other physiological parameters, which are turning out to be much more important drivers of CSF flow, at least on imaging investigations. So to do that, we need to develop better methods of studying CSF flow. And we did that using fluorescent tracers. So this is a needle entering the cisterna magna in a rat for experimental model. And in that setup, we can look at the macroscopic distribution of the CSF tracer, as well as in the same animal, look at the microscopic distribution and get quantitative analysis of spread through the CNS. And just to show you an example of the sort of experiment we can do, this is a diagrammatic illustration of this view here, where the needle is in the cisterna magna. We have dissected off the muscle here to expose the cervical and thoracic spine in this animal. And so we can, with a live view using ICG, using our neurosurgery microscopes, demonstrate the flow of CSF. Here we've injected ICG into the cisterna magna that we can see with the fluorescence channel on the microscope. This is the white light view. And what we're seeing here is the distribution of that fluorescent tracer down the cervical spine. C2 is very thick, and so we don't actually see the signals through C2. But what we're demonstrating here is that for an animal that is anesthetized but free breathing, so has periods of negative intrathoracic pressure, the distribution of tracer in the subarachnoid space is much greater than if the animal is mechanically ventilated, so there are no periods of negative thoracic pressure. And we're able to then look at those same animals microscopically and confirm that CSF flow, not only in the subarachnoid space, but penetrating into the cord, is much greater if there are periods of negative respiratory pressure. If we examine the effect of heart rate, we find that there's only a slight increase with tachycardia. With hypertension, there's actually a reduction of flow into the spinal cord. And this fits with recent work by the Nadia group, showing that this is work where they're looking at particle tracing in the perivascular space, and showed that in hypertensive animals, the velocity of the particles moving in the perivascular spaces is reduced. It's kind of counterintuitive. We showed that a similar finding in the spinal cord. This is technically much more difficult to do than in the surface of the brain. But we showed that in vessels inside the spinal cord, in hypertensive animals, the velocity of particle movement in the perivascular spaces is actually reduced. So then we've found these things in summary, that there are these influences on spinal flow related to pulsations. But then we turned our attention to spinal fluid outflow. So in these experiments, we inject tracer either into the grey matter of the spinal cord or the white matter of the spinal cord, and then monitor the movement of that tracer. And I won't go through all the details, but what we did show is that the longitudinal movement of the tracer was surprisingly short. It doesn't move, fluid does not appear to move very far up and down the cord. The movement is affected by hypertension and tachycardia that increase the outflow, but there is no effective respiration pressure on fluid outflow. We haven't yet been able to study arterial pulsations because that relies on a larger animal model. We're particularly interested in whether the spinal cord has the same architecture or CSF physiology function as has been suggested in the brain. I just would mention this is highly controversial, but if we think about it as a simple matter of CSF flowing from the arteries to the veins, as has been suggested in the brain, we have clear evidence that this is not the case in the spinal cord. These are images taken after intraparenchymal injection, and we have clear evidence of tracer here, which is the green fluorescent signal around arteries, so around arterioles, around veins, and even in the anterior spinal artery. So, and also into the central canal. So CSF outflow from the cord seems to be much more complex than it might be in the brain. So we've built up this picture now of what, of some of the physiological parameters affecting CSF flow in the normal spinal cord. We haven't specifically examined absorption, but just to reiterate that it is not a simple matter of CSF being absorbed into the arachnoid granulations. And just coming back to the point I made earlier, one way I think of this, it's just like the peritoneal cavity. Whereas in the peritoneal cavity, organs penetrate into this closed system. It's almost like in the central nervous system, the arteries penetrate that system and there is a blood-brain barrier, but it's very important to remember that outside barrier, the arachnoid tight junctions that line the dura. So having studied normal physiology, we wanted to know what happens in Syringomyelia, and in particular in what are the pathways of fluid flow in syrinx types, and what is the effect on the CSF physiology of the various types of pathology that we see that form syrinxes. So we've used various animal models. There's an animal model of canalicular Syringomyelia. We've used a couple of animal models of post-traumatic Syringomyelia, that's the extracanalicular type. One where we inject with kaolin and quisqualic acid. Another one where we use a computer-controlled impactor, which I guess is more physiological in the sense that it replicates the injury. We've also used a model where we tie a suture around the dura just to constrict the subarachnoid space, and we tighten that just enough so that it obstructs the CSF movement, but the animal retains its function. And we showed in these models that, that the CSF flow from the prevascular spaces continues into the syrinx cavity, even as it's getting bigger. So even as presumably the pressure inside that cavity is increasing, that CSF flow from the perivascular space into that cavity continues, both in the canalicular type and in the post-traumatic extracanalicular type. It was when we were studying the extracanalicular flow that we came across this very interesting finding. So these images are taken from different levels of the cervical spinal cord, C5 and C8, in the same animal, where the tracer is injected in the cisterna magna. And this finding was quite easily replicated, that the CSF seemed to penetrate the cord much more quickly and more vigorously at the level of injury than it did closer to the level of injection. Right? So the tracer has been injected cisterna magna, but it gets into the lower levels of the cord much more quickly. And so we turned to some computational modeling to investigate that a bit further. Here in a two-dimensional model looking at various degrees of obstruction in the subarachnoid space and the impact that that would have on the pulse wave as it travels down the subarachnoid space. We looked at some three-dimensional modeling using human MR imaging as the underlying anatomical basis, and demonstrated that dorsal obstructions in the subarachnoid space are much more likely to impact on the pressures in the subarachnoid space than our ventral obstructions. And this fits with our clinical observation, I think, that dorsal arachnoiditis is a much more potent instigator of syringomyelia than ventral. If you look at the effect of the constriction here, on the left are normal animals at 10 and 20 minutes. And with constriction, we demonstrated, so the arrow shows the level of constriction. What we showed here was reinforcement of that earlier observation that tracer injected into the cisterna magna enters the spinal cord down here much more, much faster and to a much greater extent than it does in normal animals. And we showed the same thing microscopically. So for control animals, the tracer here in green, yes, it gets to the central canal, but in constriction animals at the same level, there is a much greater inflow of CSF into the cord at that level. In terms of what impact the Chiari malformation might have, we think that's likely to be much more complex, but we've suggested that there's a possibility that the Chiari malformation has an impact on the phase difference between the arterial pulse and the subarachnoid pulse. So with Chiari malformation, there is no reason to think that the arterial pulse entering the cord is delayed in any fashion, but it's possible that the subarachnoid CSF pulse is delayed coming from the head into the spine. And if that's the case, then the CSF pulse might reach the cord at a slightly later time than the arterial pulse, and that might give it greater entry into the perivascular space than it would otherwise have. Now, there's a lot of complicated modeling that's gone into that, but we've shown that there is a real potential for a significant increase in fluid flow into the cord, even with very slight alterations in phase difference. And when we studied that in human patients, we showed that indeed there is a phase difference in Chiari patients and control patients, so that for Chiari patients, the pulse wave reaches the same level of the cord at a later time point. So there is a theoretical, at least, phase timing difference between the arrival of those pulsations that might explain the development of syringomyelia in those patients. So just to summarize all that, we've shown that perivascular spaces are the inflow pathway for most cases of syringomyelia. The driving force for that, I think, is still unclear. It's very likely, I think, that it's the pulsatile nature of these physiological parameters that is going to be the key, combined with the ultrastructural anatomy of the perivascular spaces that allows perhaps a kind of a one-way valve or a relative valve that CSF tends to go in one direction. We've demonstrated that subarachnoid space obstruction reduces flow in the subarachnoid space, but increases CSF flow into the cord. I think that's a critical finding here, that it's the arachnoid pathology pushing CSF into the cord that is the likely driver for these cases. And we have a theory, yet to be proven obviously, that there may be a phase difference that is the underlying problem for Chiari-related Syringomyelia. So how does all that, I mean, I've gone over that very quickly, and we've done a lot more than perhaps I've shown here, but I wanted to get into some clinical impacts here. And how does those findings of CSF physiology impact on our syrinx management? I've tried to put it in a sort of conceptual basis here that for the cranio-cervical junction, although we often hear about people wanting to re-establish CSF flow, we think it's the pulse transmission, not the actual bulk movement of CSF, that's the key here. So it may be the same thing, that we're creating a CSF space, but it's the pulse transmission, not the flow, that's the key. In the spine, it's the subarachnoid space obstruction that's the key. And again, it's not the flow across that obstruction, but the transmission of the pulse wave in the subarachnoid space across that level of obstruction. That is the key, I think, in terms of managing these cases. And if we think about that conceptual schema for CSF compartments, I think that if we're using shunts, the question of where the distal end should go, for me, it's just got to be in a normal CSF space. It can be rostral or caudal to where the shunt is, so long as it's in a normal subarachnoid space that is not impacted by the pulsatile obstruction of a subarachnoid space obstruction. And I'll show you some examples of that. So I'll go through a few examples of how these things have impacted on what we do with these types of cases. I'm just skipping over here the other aspects of particularly Chiari malformation, because I think that's beyond the scope of what I'm trying to talk about here, because clearly these patients have other things beyond syringomyelia that need to be dealt with, and the surgical goal for those things is also unclear and is something that we are wanting to work on. I mentioned earlier that most Chiari-related syrinx cavities are non-communicating. So as in this case, a very long distance from the fourth ventricle, no reason to think that there is CSF flowing from the fourth ventricle into here. But we've come to understand that there are many cases where there is a direct communication, and this communication is perhaps demonstrated best on intraoperative ultrasound, where you can often see the central canal connection between the fourth ventricle and the syrinx cavity. For this type, these patients with what might seem to be a small syrinx right at the top of the cord tend to be very symptomatic, and I think that's because the CSF really is being driven in with high pressure into those syrinx cavities. But there can be quite extensive syrinx cavities. And in these patients, there will often or usually be an obstruction to CSF outflow from the fourth ventricle, as in this patient with a membrane across the foramen of Magendie. And the management here is to explore that, open the membrane. And in some cases, if we can't do that effectively, I'll put in a shunt from the fourth ventricle into the spinal subarachnoid space. And that approach is generally very effective. So if I look at my own experience, for 93 Chiari-related syrinx patients, out of 92 of them, one operation has been sufficient to cause collapse of the syrinx cavity. This is the one child where I did not achieve that at one operation. I had to then come back and resect the tonsils to get some reduction in syrinx cavity. Note the skull base abnormality, and I accept that there may be a component of the pathology here that's contributing to that particular case. But I think our approach here has been quite successful. So for patients that I've seen where they've come having had Chiari surgery elsewhere but have a persistent or recurrent syrinx, the problems tend to be inadequate decompression, tethering or scarring, particularly from using DuraGen grafts, or some other abnormality causing scarring of the fourth ventricle outlets, and in particular using DuraGen, or in cases where the dura has been left open, as tends to be done in Great Britain. So these are cases showing the kind of scarring and tethering that can occur with those kinds of approaches. This is a DuraGen case, a case of pseudomeningocele. And my approach for these cases is generally to try to revise the posterior fossa decompression to create a better cisterna magna. This is the kind of finding we have with DuraGen. And it's a sharp division of all these adhesions. Again, making sure that the fourth ventricle opening is patent, and that will often include putting in a shunt. Here I'm using a lumboperitoneal shunt tube. I've come to understand that they're too small, and I always now use a larger ventricular catheter sized shunt. So in the revision cases that we've done, I've had 34 of those cases. 11 of those have had a syrinx, and 8 of those have had successful reduction of the syrinx cavity with revision posterior fossa decompression as shown here. And in 3 of them, we've had to then go on and do secondary shunt operations. A separate category, although probably physiologically very similar, is the cranio-cervical junction arachnoiditis. And these are patients, this patient has had a traumatic birth, but there can be post-surgical aneurysm patients, for example, tumor patients, where there is scarring at the cranio-cervical junction. And I'll show here that kind of dynamic imaging that we have really turned to show this pathology clearly. It's not clear on this T2 image, I don't think, where the pathology might be, and you might be thinking it's in the spine, but it's clear in the dynamic imaging that there is scarring here at the cranio-cervical junction. And at operation, there is a very definite arachnoid scar that matched that imaging appearance. Again, it's a matter of allowing CSF pulse transmission or fluid transmission across that arachnoid band, and here using a Bactocele catheter. This is the kind of outcome we get with those patients. So I will almost always use a fourth ventricle to spinal subarachnoid shunt with those cranio-cervical junction arachnoiditis patients. We demonstrated in this publication that for those patients, they are almost always communicating syrinxes. So it is obstruction of outflow from the fourth ventricle that tends to be the problem. If we think about what might be called idiopathic Syringomyelia, it's difficult to get much from the literature. There are very small, very few series, and they're small series, although I think most of us would understand that they are relatively common. And I'll just remind you of the laboratory studies we did showing that arachnoid obstruction is the key to driving CSF flow into the cord. And so for this kind of case, what we're looking for is where is the obstruction in the subarachnoid space? And we've in the past used phase contrast imaging, but now we've turned more to the cardiac gated high T2 images that in this case, I hope you can see, demonstrate a membrane. It's usually at one end of the syrinx. It's usually where the syrinx cavity changes in dimension. That is the underlying pathology. And at operation, intraoperative ultrasound again demonstrates that arachnoid membrane. This person's not had any trauma or infection. This is a congenital membrane. Clearly demonstrated that operation to be separating the CSF compartments rostrally and caudally, and dividing that arachnoid membrane is the key to dealing with that syrinx. And that's the postoperative result in that case. So for those cases, I wouldn't really call them idiopathic anymore because we can find the underlying pathology. This is the type of case that is difficult because the cord expansion occupies the whole subarachnoid space. Even if there is arachnoid pathology here, we can't see it even on the dynamic imaging. And at operation, I can find no arachnoid pathology, but those cases respond very well to syrinx to subarachnoid shunt. This is another case where the patient had 2 syrinx cavities, one in the cervical spine, one in the thoracic spine, and a syrinx shunt in the thoracic cavity resolves both cavities. I've got several patients where this has been the case. I've also circled this to show that the shunt here goes from the syrinx cavity in a rostral direction. And you might think that that's a little counterintuitive, that you might want to always point it in a caudal direction, but it doesn't actually matter. The CSF pulse, as it comes down the subarachnoid space, has a really long wavelength. It's well over 1 meter. And so it doesn't actually matter what direction you have the shunt tube pointing. So I tend to orientate the shunts according to the what shape the syrinx cavity is. So if I'm entering the syrinx cavity here, I will direct the syrinx shunt caudally. You might say that this is not an idiopathic case. You might say that this is secondary to that disc protrusion causing compression of the cord, but this is the same patient 9 years earlier. she had the syrinx cavity before she had the disc protrusion. It's possibly this compression here in the dorsal subarachnoid space that's responsible. And she became symptomatic at this point, and I treated her with a shunt. And you might say that shunting the syrinx is a new treatment for cervical disc protrusion, because that seemed to get better. This is a patient where she was first seen at an outside institution, and the diagnosis was suggested to be a neoplastic condition. But without dynamic imaging, we were able to demonstrate that that's a single arachnoid membrane causing what appears to be a complex syrinx. And at operation, similar to the previous case, there's an arachnoid membrane very clearly separating rostral and caudal CSF compartments. And that's the postoperative result in that case. This is was a very informative case for me. This is a patient who had a spontaneous spinal subdural and subarachnoid hemorrhage resulting in arachnoiditis and then progressive myelopathy related to this cord edema. And I suggested to him at this point that we should operate and address that. He refused surgery and came back a year later with worsening myelopathy and now definite syrinx cavity. And so I operated on him thinking that this was the point of arachnoid adhesion, and that I needed to connect this subarachnoid space with that subarachnoid space, which I did by putting in a catheter from that subarachnoid space caudally down there, as well as a small syrinx shunt. But he came back in the early postoperative period with a larger syrinx, and the problem was I had missed the arachnoid adhesion more caudally, and so the subarachnoid space here is obstructed more caudally than I had expected, and so that was allowing CSF to be driven still into the syrinx cavity. And so all I did to address that was to take the laminectomy further down and put another shunt tube from that subarachnoid space into the more caudal subarachnoid space, and that resolved the syrinx. Just another example of arachnoid membrane as the underlying cause, in this case the syrinx cavity more inferior than the membrane. Even arachnoiditis that extends over several levels. This is a patient who suffered a subarachnoid hemorrhage several years earlier with arachnoiditis here. We can address that, although that's more difficult. And for these cases, I'll generally put in a Gore-Tex dural expansile graft to try and expand that subarachnoid space. But for this kind of case, again, another post-subarachnoid hemorrhage patient over many more levels, she's remained relatively stable, and I'm hoping that she continues to do so, because I don't know that I'll be able to address that. So just thinking about the post-traumatic syrinx patients, I really think they're very similar to the arachnoiditis and arachnoid pathology cases. So it's all about creating a subarachnoid space that allows pulse transmission across the level of obstruction, as in this case and in that case. All we've done is open up the space, divide adhesions, expand the dura, allow pulse transmission across. This was another informative case for me. This is a patient who was treated elsewhere first. That was her original post-injury scan. She came back 6 years later with a large syrinx. She had surgery with a shunt that's been put in here and put down into the surgeon did a syrinx to subarachnoid shunt. But it turns out that the shunt tube is in the syrinx cavity here, but inferiorly, the tube is actually in the subdural space. And the key here, as I mentioned earlier, is to be inside normal CSF space, not outside the tight junctions of the arachnoid, which are the outside part component of that contained CSF space. So the key here was to get that catheter into normal subarachnoid space. This is that patient at operation. This is opening that, what I suppose is an iatrogenic arachnoid cyst, where that catheter is in the subdural space. It's become encapsulated with arachnoid. This is the deeper layer of arachnoid, which is really the ordinary or the original arachnoid, and the subarachnoid space under that was actually quite normal inferiorly. And so by just replacing that tube from that iatrogenic subdural space into what was really a normal subarachnoid space, resolved that syrinx. This is the last case I'll show, is the case I did recently just to again illustrate the complexity of CSF physiology. So this is the level of injury. At operation, there was complete separation of the dural sac above and below that injury. And yet this is full of CSF. So what I did in that case was to reconnect the dural spaces, put a catheter from the syrinx into the subarachnoid space down here. He has symptomatically improved. I've not yet got a post-operative scan. So again, just coming back to that conceptual schematic of the subarachnoid space being the key, particularly for thinking about shunts and the overall impact of CSF physiology on our understanding of this condition. There are, of course, remaining challenges. We still can't find all the subarachnoid space pathology. We need better imaging. Extensive arachnoiditis is impossible to treat, as is the small idiopathic syrinx that it may be symptomatic, but if you can't find the underlying cause, that's very difficult to treat. And I come back to the idea that we still don't really understand syrinx pathophysiology. I published this paper a couple of years ago. I was very proud of this paper because I think it was really a demonstration of how we had used our understanding of CSF physiology to manage patients. And I published here 41 cases of syrinx to subarachnoid shunting. But of course, like most things in surgery, nothing's new. So Dr. Tator published 40 patients 30 years ago. So we've come maybe a little way in understanding CSF physiology, but still standing on the shoulders of our mentors. So I will thank you for your attention and also acknowledge the support we get from funding foundations, particularly the Column of Hope, which is a foundation based in Buffalo that funds a lot of our basic science and clinical research. And of course, all the people who have been involved in this research work over many years. Thanks again for your attention.
This is the point at which there is thunderous virtual applause for a magnificent lecture. Thank you so much. Some great cases and a lot of really excellent insights. So to the audience, would kindly ask that you type in your questions. The panelists are able to kind of ask questions directly, but I might sort of begin by asking a couple of questions. So one relates to the phenomenon that you nicely illustrated and commented upon, where typically in a Chiari that's associated with the syrinx is actually quite distal, often around C6, C7, as you showed in your case. And clearly that can't be explained simply by a communication between the fourth ventricle and the central canal. So what is your best guess in terms of what is going on in those types of cases?
Well, as I kind of alluded to, we think it's got to be it has to be related to the pulsation and probably cardiac pulsations. I think respiratory pulsations are definitely a potent driver of CSF flow, but I think my hunch, I suppose, is still that it's going to be cardiac. And my engineering colleagues and I have talked about this a lot, and we think that it can't just be the piston effect. It can't be an increase in CSF pressure on the outside of the cord, because that just squashes the cord. It can't force fluid in. So it's got to be related to the shape of the perivascular space with the tapering shape that somehow, with variations in pulsatility, that CSF is able to go down the perivascular space, but has difficulty going out. And whether that's related to a change or a difference in the arrival of the arterial pulse wave and the CSF pulse wave impacted by the Chiari is a possibility. And certainly our computational modeling suggests that that's quite feasible. And it might explain the location of the syrinx cavity, that it's related to the timing of the pulse wave as it reaches that part of the cord.
I see.
But as I showed, though, there are definitely the communicating cases. They're the minority, but I think the pathology in those is different.
Right, right. And you showed a few case examples of it. There's a question from the audience in the Q&A, and a question, and now a couple of questions. A question from Dr. Pereira. do you use stitches to keep the drains in place? I presume they mean kind of a stitch through the arachnoid. Do you do that?
Yes, I do. So I use an 8/0 nylon suture. I used to use a finer suture than that, but I had a couple break and had to reoperate. So I've turned to 8/0, which seems to be the right size, and I put it through the catheter and sutured either to arachnoid or to the inner part of the dura. Yeah, I do the same. That's exactly what I do. And a question from one of our residents, Dr. Mogadamju, going back to the pathophysiology, do you think, in general, do you think that Syringomyelia is an acquired or a congenital pathology? Well, I think it's almost always acquired. The congenital cases, I suppose, would be particularly the spina bifida cases, where it's really just a hollow syrinx in continuity with hydrocephalus. But otherwise, it's acquired in relation to all of those other conditions that I listed. Okay. And I had a question, and again, if any of the panelists wish...
Can I ask a question?
Yes, for sure.
Dr. Stoodley, thank you very much for your great talk. You know, I took note of one of the cases of your that you operated on with the dorsal arachnoid web with a significant syrinx, and that seems to be one of the more kind of home run situations for patients with syrinx that can be treated with a kind of a quick operation that you usually do fairly well from. But from a technical perspective, when you see different people do these and read about how they do them, often some of them, in addition to lysing the arachnoid adhesions, will also drain the syrinx. And do you think that there's a need for that? Or is that something you do selectively or not at all?
Thanks, Jeff. I deliberately avoided talking about that. My own practice is that usually it's a large syrinx, and and often you can see the syrinx through translucent pier, and in those cases I put a shunt in. I mean, conceptually, dealing with the arachnoid pathology is probably all that's required, but I suppose the concern is that the scar might reform. And so in cases where there is no additional morbidity for putting in a shunt, then I'll do that. Okay. Okay. Question from one of our faculty, Dr. Ginsberg, and this has to do with the use of intraoperative ultrasound. And Dr. Ginsberg notes that after a Chiari a decompression, he notes that the tonsils pulse directly downward like a piston. And then he finds that after duroplasty, the direction of the tonsillar pulsation is different. And have you seen this, and what do you think this means? Yeah, so we've actually published our findings on the MR measurements of tonsil motion pre and post operatively. It's tiny. I mean, the tonsil motion is only a couple of millimeters, and but it definitely reduces after post-hypostyle decompression. Intraoperatively, I do intraoperative ultrasound, and we see the tonsils push down in what might be called a piston motion, and it improves after duroplasty. That's true. It's a bit hard to measure though with ultrasound. But the question is, you know, is it the tonsil motion or is it the CSF pulse wave that's the key? And if it's the CSF pulse wave, it doesn't really matter how you achieve that. So, for example, the large Chinese group who just come in with a very minimally invasive approach and resect the tonsils are achieving the same thing. Interesting. There's a question on whether you still think there's a role for 3D and 4D phase contrast flow imaging, or is this no longer really of value? Yeah, I mean, I did go over that pretty quickly. We rely pretty heavily on the anatomical cardiac gated images, but we correlate that with phase contrast. And it gives us a lot of confidence if it all matches. If we see a change in the phase contrast at the point of the arachnoid pathology, then we're pretty confident that's the point. So the answer is yes, there's definitely a role still for that imaging. Okay.
Michael, I have a question.
Oh, Dr. Tator, please.
Marcus, that was a lovely talk. You might have said this, but I may have missed it. If you are operating on a Chiari with syrinx, do you do it in one stage? Like, would you just do a posterior fossa decompression and expect the syrinx to disappear, or do you ever think there's an indication for putting a shunt in as well as operating on the posterior fossa?
Yeah, that's a great question, because that has been the approach for some people in the past. My own view is that if we can achieve a good cisterna magna at the cranio-cervical junction, then the syrinx will go away. And as I showed, out of 93 Chiari-related syrinx patients that I've been the first operator, they've all got better with posterior fossa surgery. I've not had a single patient where I've needed to go to a shunt. For patients who present having had surgery elsewhere with a lot of posterior fossa or cranio-cervical junction arachnoiditis scarring, for some of those patients I've had to turn to a shunt.
And in the typical case where there's both the decompression of the posterior fossa in the presence of a large syrinx, let's say, what is your usual technique for duroplasty? Well, I guess the question should also include, do you do a duroplasty in every case? And if so, what do you use?
I do a duroplasty, and I currently use pericranium. I used to use Gore-Tex, but they stopped making the particular patch that I was using, which was a nice thin Gore-Tex. And it's one of those things that you get from attending, I guess, specific conferences. And if you talk to people who do a lot of Chiari malformation surgery, they all use pericranium. And so, or Gore-Tex. I know a lot of people do use Duragen and that type of material. I'm trying to make the point here that has potential problems. Pericranium has been very, very good in my experience. It's good for watertight closure and is flexible to allow a large cisterna magna.
Thank you.
One thing, just in terms of the technical aspects, the more I do, the more my threshold for doing something with the tonsils, usually coagulating the tonsils to shrink them, is lowering. And again, if you talk to people who do a lot, they will almost always shrink the tonsils.
Interesting. I think on that note, I know there are some other questions that are in the Q&A panel, but in the spirit of trying to stay on time and to move things forward, I think Professor Stoodley would like to thank you very much for an outstanding lecture. We're going to take a short break, 3 to 5 minutes, and then we're going to then transition into a session on the craniovertebral junction with a particular focus on Ehlers-Danlos syndrome. And just while you're taking a break, we have just a short video to provide you with an artist's concept of the impact of the COVID-19 pandemic and how we've been dealing with this and how we might emerge. So Terry, if perhaps you'd show the video. We'll resume in a few minutes for our symposium. Thank you. Okay, I think we, in the spirit of moving forward, we'll start with a part 2 of our symposium, and we have organized a special session to discuss the craniovertebral junction with a particular focus on Ehlers-Danlos syndrome. We have 2 excellent speakers, and then we have some panelists representing the leadership from the Ehlers-Danlos clinic at the Toronto General Hospital, and I'll introduce those panelists subsequently. But to lead things off, I'd like to introduce Dr. Jefferson Wilson. Jeff is a clinician scientist in the Department of Surgery at St. Michael's Hospital, and is an assistant professor in the Division of Neurosurgery. And Jeff will speak on cranio-cervical hypermobility syndromes, Chiari EDS, and the role of fusion.
Thanks. Michael, can you see my slides okay?
Yes, we can. Yes.
Thanks very much for the introduction, and welcome again, Dr. Stoodley. Sorry you couldn't be face-to-face, and really enjoyed your wonderful talk. I gave a similar talk about a year ago at a meeting that Dr. Stoodley was chairing in Buffalo, and I wish that I could say that there's been a mountain of evidence has accumulated in the interim between now and then, but I think the reality is that there isn't. But I think it's still useful to know, or to present what we do know about this topic, and more so as a launching point for discussion and to outline possible future directions. Those are my disclosures. So as we all know, the occipital cervical junction is an important anatomical crossroads. And it's also a relatively frequent site of pathology of many different types. And in certain circumstances, this pathology can lead to compromise of the structural integrity of the occipital cervical junction, which can lead to pain in certain circumstances, but also in more extreme examples can lead to compromise of the underlying neurologic tissues and progressive neurologic deficits. I think one thing that we can say for sure is that over the years, we've become increasingly facile with reconstituting the structural integrity of the OC junction. And we've seen an evolution of different implant types, from wires to plates to now rigid intersegmental fixation. So while we're quite good at achieving surgical goals, and the techniques and technologies have come a long way, I think it's still important to point out that this surgery is associated with a number of possible adverse events, including rare but relatively serious events such as neurologic damage or stroke, and then less severe but more frequent postoperative adverse events that can be impediments to good patient outcomes. So I think this is just a caveat to say that this surgery is not like prescribing a medicine or doing physiotherapy. There is a recognized risk, recognized series of adverse events, and that patient selection is really paramount. I want to talk a little bit about OC fusion in the setting of heritable hypermobility syndromes, which is really a grab bag term for a number of different heterogeneous group of disorders and diseases, many of which you've heard of before. More relevant to this talk is a hypermobility syndrome called Ehlers-Danlos syndrome, which in and of itself is really a heterogeneous group of clinical disorders. In fact, there are 14 subtypes, as many of you may know. They range in severity from really subclinical to barely noticeable to life-threatening. And while most have a well-defined underlying genetic basis, in fact, the most common type, the hypermobile EDS, which is mostly relevant to what we're talking about today, has a genetic basis that is yet to be completely elucidated. When we talk about how we diagnose hypermobile EDS, it's really based on a clinical diagnosis that was put forth by a consortium in 2017, based on presence of generalized joint hypermobility, evidence of syndromic features, and then exclusion of alternative diagnoses. The epidemiology of this condition is estimated to, from a prevalence perspective, to be about 1 in 5,000 to 1 in 20,000, but this is probably a very unexact estimate, given the fact that there are a number of people probably with a more milder version of this syndrome who don't ever present to medical attention or get diagnosed. Of course, this is really a systemic syndrome affecting multiple areas of the body, most notably recurrent MSK, joint-related dislocations or subluxation, a number of chronic pain syndromes resulting from this, including joint pain, neuropathic pain, migraines, and it affects a number of the other systems body-wide, CV, ocular, obstetrical, gynecologic-related issues, in addition to a high prevalence of psychiatric comorbidities. Relevant to us, I think it's important to understand that there may be an association between Chiari and hereditary connective tissue disorders such as EDS. In this very large series of about 2,800 patients with Chiari-1, about 12% had EDS or a similar equivalent, which is a much higher incidence than what we would expect in the general population of these sort of syndromes. And the exact underlying genetic basis for this is unknown, but we do know that those with Chiari and these hereditary connective tissue disorders seem to have a slightly different phenotype. They seem to be more likely to be female and have a more kyphotic angulation in the way of a reduced clival axial angle through the OC junction. Just as a little bit of pretext and background, this is one of the key radiologic variables that's used often throughout this literature to look at alignment through the occipital cervical junction, the so-called clival axial angle. In general, around 150 inflection is considered normal. The lower that the value is indicative of more extensive kyphosis throughout the OC junction, and that's used as a proxy to really judge the so-called fulcrum effect, where with increased kyphotic angulation through the OC junction, there's increased tension on the neural elements and distortion across the cervical medullary junction. Of course, this has been criticized by a number of different authors. It's a bit of an inexact measurement. It varies a lot between flexion and extension, and it's really just a poor proxy for what's actually happening to the neurologic elements underneath. But nonetheless, it's often used throughout the literature. So getting to really the meat of this, surgeons, we want to know how this affects us, from what sort of surgical procedure we should be thinking about and how we should be counseling these patients. First is, should patients with Chiari malformation in general, without a hypermobility syndrome, be considered for occipital cervical fusion? There is not a lot of literature on this. And one of the largest studies actually comes from the pediatric world, paper done by Doug Brockmeyer and colleagues at the University of Utah at Salt Lake City. And they had 100 patients with Chiari-1 that underwent surgery. 82 of these underwent decompression alone. 19 of these underwent concomitant fusion at the time of initial decompression, or in a delayed fashion after decompression fused, or decompression alone failed. And they went on to try to perform univariate and then multivariable analyses of factors that were predictive of need for fusion. And this is a univariate analysis, which is a bit complicated, but in the multivariable analysis, they found that a number of variables, radiographically speaking, were associated with need for fusion, including the presence of a Chiari 1.5 malformation, the presence of basilar invagination, and then a kyphotic cranial occipital alignment measured by a cranial axial angle less than 125 degrees. There are a number of other little case series in the literature, in addition to editorials and expert opinion, including from this respected group, that really call for, in the case of an uncomplicated Chiari-1, the fact that from a surgical perspective, decompression alone is often all these patients need. There are more complicated folks in which they may also present with basilar invagination or cranial settling, or a more kyphotic occipital cervical junction, in which case judicious use of occipital cervical fusion may be useful. But in this setting, there is a paucity of evidence, and I think we can say few things with absolute certainty, but I think one of those is that most patients with Chiari-1, that is the regular patient without significant deformity at the OC junction, can be treated successfully with decompression. Those with basilar invagination are at increased risk for failure of this treatment alone, and a fusion may be considered. I'd be interested to know Dr. Stoodley's opinion on that. There are some other radiologic variables, such as a reduced clival axial angle and the presence of a Chiari 1.5 that may predict failure of a decompression alone, but more evidence is needed. I'm just going to finish with talking about how we should approach the surgical management of patients with heritable hypermobility syndromes and Chiari, and specifically whether they should undergo fusion. And I think this is really a more controversial subject, and there's even less evidence available on this particular topic, but nonetheless worth discussing. What's the rationale for fusion in such patients? Well, I think we can acknowledge that these patients do have ligamentous laxity, which can lead to some form of cranio-cervical instability, although frank dislocation or subluxation would be very rare in this patient group in the absence of trauma. But they can perhaps lead to kyphotic deformity across the OC junction with a more kyphotic OC junction and a reduced cervical occipital cervical angle. And this can lead to increased tension on the neural elements and the development of this so-called cervical medullary syndrome. And this cervical medullary syndrome is really the kind of diffuse symptom complex that one or two authors have used frequently throughout the literature to describe what happens from a chronic strain force applied to the cervical medullary junction as a consequence of OC deformity. And you can see that there's really a whole host of very systemic symptoms that can develop, from visual loss, hearing loss, balance loss, dizziness, sleep disruption, dysautonomia, etc. The goal here, I guess, theoretically, is to realign the OC junction, to decompress the neural elements, to perform a fusion, and to prevent progression of such symptoms and hopefully symptom amelioration. At least that's the goal. From an evidence perspective, unfortunately, there's not much to hang our hat on. This is the paper that's oft cited, and it's really, I guess, the best evidence, if you can say that, for what's available. The first author is Fraser Henderson, who is noteworthy for performing surgery on a number of these patients. He has an in-depth interest in patients with hereditary hypermobility syndromes and cranio-cervical junction abnormalities. This is a paper. It was really a retrospective case series of 20 patients. All patients had intractable headaches or neck pain with some elements of the cervical medullary syndrome, which I just briefly discussed. They had a heritable connective tissue disorder like Ehlers Danlos or analogs. And they had a kyphotic clival axial angle of less than 135 degrees, although the imaging protocol wasn't very uniform in its application across the patients included. All patients did undergo surgery in the way of an occipital cervical fusion with open reduction and decompression of the posterior fossa. They were followed up to 5 years. In terms of outcomes, they reported that all patients fused. There were no deaths or serious peri-op morbidities. There were 2 wound infections. 8 of the patients had to have their hardware removed due to pain in this region going forward. One of the biggest hangups with this, I think, is the way that the patient-reported outcomes were planned or reported in this series. Really, they looked at subjective reports of how patients reported their quality of life. They wanted to ask if, looking back in time, would they still choose to have this surgery? If they could do it over again, would they recommend this to their family if they had a similar issue? And was the quality of life improved in kind of broad strokes? And really, this sort of measurement is fraught with a lot of difficulties and bias, and probably not the best way to do it. They also looked at Karnofsky scores, which are usually reserved for assessments of function in cancer. There was no other formal assessment of quality of life in any sort of subjective way using validated PROMs. I think there are some strengths in this study. It's one of the few to actually look at this subgroup. They did report long-term follow-up rates, but there are a number of limitations. It's a very small series. There's no control group, and the outcomes used probably were not the most robust. So what are we left with? So there are a number of unanswered questions, and few of these have any real great answers at this juncture. I think one of the key things here is that this is, again, a systemic syndrome, these heritable hyperconnective tissue diseases, and they have very systemic symptoms. And I don't think it would be right or certain to say that all the patient's symptoms that are reported under the umbrella of this cervical medullary symptom can really be attributed to the so-called strain force across the distal part of the brainstem and upper cervical spine. And it's possible that some of these symptoms can be coming from peripheral or more systemic manifestations of the underlying disease. So really, what is coming from what? And can we fix all these problems by fusing the patient's head to their neck? I don't think we know that yet. The other comment is that we're this is slide was from last year, but now we're in 2020. Apologize for that. But we're in 2020, and we have very sophisticated ways to look at the underlying neuroanatomy using more advanced imaging modalities like DTI, tractography, functional MRI. Instead of using these more rough estimates based on kind of surrogate measurements from the bony anatomy, we should be looking actually what's happening at the neuroanatomy microstructure and using this to correlate with symptoms and understanding kind of what's causing what at a more in-depth scientific anatomical basis. There's a lot of heterogeneity in patients that have heritable hypermobility syndromes, and I don't think we can treat them all in kind of a one-size-fits-all approach. Prospective data collection may lead to us understanding subgroups that will benefit from this sort of surgery and this sort of treatment, but we don't know what those are yet. One of the last things I wanted to talk about is we can't ignore the fact that in the general patients population that we do cervical fusions on, there's a substantial risk amortized over time of developing adjacent segment problems. In patients with hypermobility syndromes, we could anticipate that these problems would be, in fact, exaggerated. And even though it's not reported in Henderson's paper very well, when I saw him give a talk in Buffalo last year, and when pressed on this a bit, he does acknowledge that, in fact, a lot of these patients end up having subsequent surgeries, not only distal extensions of their OC construct, but subaxial cervical spine issues and need for anterior approaches, et cetera. And so in this context, one has to ask the question very reasonably, does the treatment become worse than the underlying disease itself? And I think we don't know that yet. Finally, this is kind of a plea for where we should go in the future. I think we won't resolve much until prospective research is done. And I do acknowledge that an RCT on this topic would be very difficult, but there would be some opportunity for more high quality observational research with control arm, perhaps non-operative structured physiotherapy, pain management, et cetera. And this may allow us to identify with a little more accuracy what subgroups may benefit from surgery. And of course, the use of validated generic or disease-specific outcome measures would help things in addition. So again, I'm sorry that I'm really leaving you with more questions than answered, but I do think it's really the state of what's in front of us in terms of literature and research. And I do think that there's opportunity to do better for this patient group. I know that there's a lot of patients that are suffering with these sort of conditions, and they're indeed desperate to get better and desperate for answers. And I do not think that the right approach in dealing with this group is to offer a one-size-fits-all surgical occipital cervical fusion, but rather the study of these patients in well-defined research protocols where we can have a better understanding of who does well with what. Thanks very much for your attention.
Thank you very much, Jeff, for that excellent lecture. I think we'll hold questions until the panel discussion, and at this point we'll call upon our Tator-Hall visiting speaker, Professor Stoodley from Macquarie University, to give a brief address on craniovertebral junction symptoms, imaging, and surgical indications.
Thanks, Michael. I will start by just to disclose that I'm not an expert in the sense of coming to this field from the point of view of being a spine surgeon. I've come to this from the point of view of someone who looks after a lot of patients with Chiari malformation and watching the evolution of this as a focus, particularly for patients with EDS. And so that's my perspective. Whereas I think a lot of the people in this field have come to it from the point of view of spine surgery. I think of it like this: so there's a classical view of what I suppose is the view that I had before this evolution, and then these new concepts of the cervical medullary syndrome and atlantoaxial instability, and then just closing with what I do or we do at Macquarie. So from a classical point of view, abnormalities of the cranio-cervical junction have been well known and related to abnormal movement either at the occipital cervical or C1, C2 movement, combined possibly with basilar invagination. And traditionally, I think this has generally been thought of as a problem of brainstem or upper cervical cord compression. And for those patients, there's no question that the problem is related to compression. And there are many measurements that can be made, dynamic and static, that indicate whether there is likely to be compression. And that was the point of these measurements, was to determine what is the likely extent of compression of neural structures that that might be leading to symptoms. So in particular, the distance between the C1 and the DENS, the distance, the Grab-Oakes line, which is an indication of how likely it is that the brainstem is being compressed, and as Jeff said, the clival axis angle. So in that view, the symptoms are related to brainstem or cervical cord compression, so gait abnormalities, balance problems, swallowing, cranial nerve problems, weakness, numbness, proprioception, and sometimes headache. And that the indications for surgery are for patients who are symptomatic with objective neurological signs and evidence of brainstem or cord compression, and I've underlined compression. So these patients definitely exist, and here's one of ours. So a man in his 60s who presented with symptoms related to brainstem compression and had abnormal signs with Romberg's positive, hyperreflexic and cranial nerve signs, and imaging evidence of assimilation of C1 to the occiput, and instability here in terms of a change in the axis DENS interval, and the Grab-Oakes line being quite significant, 15 millimeters. And so that's the sort of patient we would treat with a fusion, plus or minus decompression, and with good clinical results. So there is a reduction in the compression of the brainstem, and he does well clinically. If we then turn to this concept of the cervical medullary syndrome, which Jeff also talked about and listed here in Henderson's paper, he compares it to what he calls pure Chiari, where patients present with cough or Valsalva type headache, possibly with cerebellar dysfunction, although I have to say that's pretty uncommon in my practice, lower cranial nerve deficits and gait disturbance, versus what he calls complex Chiari with ventral brainstem compression or craniocervical instability. I've emphasized the or, because I think this is key here, that there is a kind of implication in all of this that there may be compression, or maybe that now evolving and understanding that compression may not be necessary for these patients to develop neurological abnormalities. So compression or instability. And then you saw the list that Jeff gave, which is the same list here, that these patients present with this myriad of neurological symptoms, or neurological and other symptoms. And the concept here is that compression is not necessary, that it's the lengthening of the brainstem and stretching of the brain or the cord with movement that is responsible for these neurological abnormalities, the so-called cervical medullary syndrome. My concerns with that are, is it really possible for people to have neurological symptoms related to this pathophysiology without compression? And I suppose the only other situation I could think of that might be similar is for a patient with a real tethered cord presenting with neurological symptoms, particularly bladder disturbance, lower limb sensory symptoms. There's no compression of the spinal cord, it's a stretching, and it may be similar. And that's the argument that Fraser Henderson makes, that these patients have stretching of the brainstem. As Jeff said, it's really based on the only literature evidence is a very small series. And I have a significant concern about the highly invasive nature of this surgery in what is generally very young patients. The cohort published by Fraser, I think the average age was early 20s. And that's a lot of time to develop long-term complications. If we then turn to the other new concept of atlantoaxial instability, and this is the concept promoted by Atul Goel. And he describes three types where the atlas is subluxed anteriorly on the axis, type 2 where it's subluxed posteriorly, and type 3 where the joints align, but there is this perception that there is somehow a kind of a longitudinal instability. And the way he describes it is that these patients have other imaging abnormalities to suggest instability, or that it can be confirmed intraoperatively by manual manipulation. And in a sense, this, to me, becomes a bit of a circular argument, because he says that Chiari malformation and syrinx are manifestations of instability. Therefore, if a patient has one of these, they have instability, and so it goes around in circles. Again, compression is not necessary in this concept. So Goel argues that all of these types, all types 1, 2, and 3, should be treated with C1-2 fixation. And he suggests that all Chiari and syrinx patients, and notably recently, he's promoting this idea that even idiopathic Syringomyelia can be treated with C1-2 fixation. The clinical features he describes can be roughly grouped into musculoskeletal and neurological. Again, they're protean, they're very non-specific symptoms. And the thing that's notable from Goel's publications are the really dramatic images. So we just don't see patients like that, whereas his publications are full of patients with this kind of abnormality. Again, here, this very severe skull base abnormality, which we just see very rarely. And you'll note that for these patients that he gives the, the images for, the post-operative imaging is generally just the CT. And it's only very rarely that he will demonstrate a syrinx outcome. So here is one example where there is C1, C2 fixation for Chiari plus syrinx, skull base abnormality, and there's a syrinx outcome. In general, he doesn't show the MRIs, and he says that the outcome is based on the clinical features and that these patients all get better. So my concerns about this concept are that the patient population seems very different to what we see. And I've suggested this to Atul, and he says we're all human, and no difference between Indian humans and humans in other parts of the world. But we just don't see patients with abnormalities like that. It seems unlikely that C1, C2 fixation is the answer to everything. And as I said, the outcomes tend to be clinical, so the patients all get better rather than other more objective features. So in our practice, I think there is a role for fixation, particularly for that first, what I'm called classical instability and compression presentation, where the patients have neurological deficits. And of course, there's been this change from an anterior decompression transoral approach to a posterior distraction and fusion, and that seems to be appropriate. This is a case of ours, posterior fossa decompression done elsewhere, presented with brainstem compression, evidence of instability, and so he has a fusion. But as Jeff alluded to, this man is in his early 20s, and after 3 years, he's had to have further surgery for adjacent segment disease. And in addition, I have many patients who have definite craniovertebral junction abnormalities, such as this patient who, again, had a posterior fossa decompression done elsewhere. He's actually completely asymptomatic, and the concern here was that the syrinx was getting bigger. And so I operated on him to do a syrinx shunt. The syrinx is better. His skull base abnormality is untreated. He is completely asymptomatic with that. As was this patient who, I'm going to have many patients like this, present with very typical features of Chiari malformation with cough-induced headache, syrinx, posterior fossa decompression, complete clinical resolution of symptoms, and syrinx reduction. So then it comes to the question of, should a fusion be considered for patients presenting with headache only? And I've just got 2 examples here. Patient with has had a posterior fossa decompression, but persisting headache, definite evidence of instability at the skull base. Another example, already had a posterior fossa decompression, abnormal clival axis angle, evidence of instability. And the only symptom for these patients is headache. Now, in our conference last year in Buffalo, I posed this question to the audience, including Henderson and Paulo Bolognese and others who do a lot of these surgeries. And I asked the question, do you ever do this operation for patients who have only headache? And the answer was an emphatic no from every single surgeon. They never do it for just headache. The patient has to have objective evidence of neurological dysfunction. So these are 2 current patients I've just shown where we're considering whether they could be managed with fusion, but that's, I think, where the great difficulty is at the moment. So there's definitely a role. The threshold must be high. Decompression and fusion would be appropriate in many cases. And here, as Jeff indicated too, there's not enough evidence in the literature to base our practice on. And of course, these patients, as Jeff said, are desperate for answers and they're easily influenced. We need more evidence. So thanks for your attention on that.
Thank you both for that, those excellent lectures. So at this point, we're going to go to the panel discussion, and I'd like to introduce our two panelists who will join Dr. Stoodley and Wilson in the discussion, and Albert and I will moderate this. Albert will try to field some of the questions from the audience, and I'll try to direct some of the discussion on the panelists. So our two panelists are Dr. Hans Clark. Dr. Clark is Director of Pain Services in the Pain Research Unit at the Toronto General Hospital. He's an Associate Professor in the Department of Anesthesiology and Pain Medicine at the University of Toronto, and he is the Director of the Good Hope Ehlers-Danlos Syndrome Clinic at the Toronto General Hospital. And he's joined by Dr. Nimish Mittal, who's an Assistant Professor in the Division of Physical Medicine and Rehabilitation at the University of Toronto. He has a focused interest in pain and musculoskeletal disorders, and he's the medical lead of the Good Hope Ehlers-Danlos Syndrome Clinic. So Drs. Mittal and Clark, thank you very much for joining us, and perhaps I might give you each kind of the initial opportunity to either comment or direct questions to our two speakers.
I guess I'll start, Michael. I guess first thing I'd like to thank you and Albert for actually bringing this topic up for discussion. When I took over the Ehlers-Danlos Clinic about 2 years ago, I can tell you that it's been quite the struggle to even get this topic addressed. And so putting it at the forefront of SpineFEST is really a colossal move on both yours and Albert's part. We've seen thousands of patients now probably come through the clinic over the past couple of years that we've been at the helm. And I would say very few of these patients need or any type of neurosurgical consultation for that matter. But when we find patients in particular, not so much with the pathology that Marcus and Jeff have been talking about, that is clearly a compression that's leading to neurological findings ongoing, but those transient neurological findings, those are where we really struggle. And I have to thank, Christian Valletta in particular, one of your colleagues, and Chris Nielsen for actually taking it upon themselves to sit down and think about how we could move this forward and get some good evidence and data as we move forward and create a clinical pathway. I'm going to let maybe Nimish jump in and give a little bit of his 2 cents and maybe ask a couple questions to Marcus and Jeff.
Thank you.
Might still be on mute there, Nimish.
Thanks, Hans. Thanks, Hans. Yeah, and thanks, Marcus and Jeff, for excellent presentations. Marcus, especially, I like the first presentation that you had was really amazing about the CSF flow physiology, and I'll come to that because I think it's hugely related to a large part of the population that we also deal with at the EDS clinic. But the question, as Hans was saying, we struggle with is we understand you said, and Jeff also said, that there should be some objective neurological findings for the patients to be seen and to get operated, but that is not what we usually see. And also, as you said, that there should be some imaging findings on radiology to show some neurological insult in these patients. However, the theoretical postulate, which has never been proven though in these patients, is that there's a dynamic instability which happens because of their lax transverse ligaments and the alar ligaments that cause either anteroposterior or kind of like a vertical compression. And so the patients, when they move through their normal ranges, which is actually abnormal, results in a dynamic insult. However, the insult is not enough to manifest as demyelination or any changes that could be caught up upon the T1 or the T2 MRIs. As such, do you have any advice or what would be your comments on about imaging in these folks? And I understand, like, we could obviously do clivaxial, the horizontal Harris and the grave nip folks, but anything else in terms of like the most common question, the fraternity, most of the patients come and ask us is there any value of standing MRI, to be very honest? What would you think? And the reason I think it's important, specifically for Chiari, the standing MRI, is you said, we talked about Chiari malformation, but we didn't talk about what is the radiological matrix to be called Chiari. I have seen radiologists around Toronto in the GTA area where I practice who would call 3 millimeters of a descent as Chiari. Some would not even call a 7 centimeter descent as Chiari. So what do you think is and obviously does not correlate with the severity of symptoms. So how do you see, how should we be tackling that? And what are your comments on what is, first of all, should be called Chiari? Is it a 3 millimeters or a 5 millimeters or a 7 millimeters? And how it should be assessed in patients when they only have dynamic instability? And does standing MRI add any value to that? Because going by the Kelly-Monroe hypotheses, when they would stand, they say that is when the sagging happens. Over to you.
Okay, so standing MRI and criteria for diagnosis of Chiari.
So maybe I could start with that. And we have sitting MRI available here, not standing MRI, but I think that's probably similar. It's very uncommon that there's a change between supine and sitting in terms of the degree of cerebellar herniation. We do that imaging when there is any doubt, but it's very uncommon that there's a change. But I take Nimish's point that it's very difficult to define what is Chiari malformation. It's not simply a matter of how many millimeters of tonsillar descent. I think it's a combination of what is the physiological, it's really the physiological impact of it. So is it causing brainstem compression? Is it impairing CSF flow, and in particular dorsal CSF flow? So many Chiari patients, the ventral CSF flow is quite normal, but on CSF flow studies, the dorsal CSF flow is abnormal. So they're the things that I would take into account. I also look at the relationship of the cerebellar tonsils to C1. So in patients where C1 is very close to the occiput, the tonsils may only be herniated 3 millimeters, but if it's down to C1 and there's no CSF space, then that's significant. So it's complex. There's no definite point of definition at the moment. There's work that needs to be done on that. Standing or sitting MRI, we do it, but not a big change.
Jeff, your thoughts?
Yeah, I have to acknowledge that standing or sitting MRI is not a big part of my practice. One, for the practical reason that it's actually quite difficult to get in the GTA and in Canada, to my knowledge. And the second is that I haven't seen any compelling data or research that really makes a difference. But I can tell you that I do think that there's a role for better imaging, and irrespective of whether the patient has a possibility of a hypermobility syndrome, I think a lot of us are moving towards, in the presence of a patient with objective clinical findings, where the static imaging is not doing justice to the clinical presentation, getting dynamic imaging and more specifically dynamic MRI, cervical MRI. And I have to say that there have been situations where flexion extension MRI has really borne out or exaggerated or shown the presence of significant cord compression or compression of the neural elements that was not visible to me on the static imaging. But that would be in the setting of significant objective findings of either cervical myelopathy or convincing symptoms of that same problem. So I think there is a role for flexion extension X-ray or flexion extension MRI, but standing or sitting MRIs is not something that.
Yeah, that's been my own experience. I've had a handful of patients where a flexion MRI has helped sort things out. Albert, we have a few questions from the audience. So the lectures are open to the audience. And did you want to perhaps handle a few of those questions, Albert?
Sure. So thank you so much, Michael. A couple of them have been answered, but there are others that I think I've sort of coalesced and sort of thematically. And you know, I think this is a great opportunity where we have tremendous experts that span non-surgical through surgical sort of approaches, and you know, recognizing you know, until such time that we potentially may have additional evidence, we're really heavily reliant on expert opinion and experiences to guide us. And you know, in this sort of area, you know, there's often challenges in terms of the correlation of symptoms with imaging features. And so we have one question relating to other options. And so, you know, there's been some discussion about the role or considerations of fusion or not. And so without fusion, what might be some other options that are available? And maybe this is something Nimish and Hans can sort of answer for us. And one of our other colleagues, clinician scientists, that also, you know, asked, you know, what is the evidence for some of the non-operative approaches as it relates to hypermobility syndrome?
So I guess, Albert, yeah, I'll try to jump in there first. I can tell you that one of the frustrations here is there seems to be a debate among the community as to, you know, fuse or not to fuse, but the question's bigger than that, and it really is, what is the best care pathway for long-term success? And for certain, the only way we're going to get to that best care pathway is to get all of the clinicians involved in these types of patient care and the academics together to create the roadmap. And we have a manuscript under review right now, just looking at that roadmap that we've built, and we've built it with our neurosurgical colleagues as we move this forward. And so, you know, we're going to have some of those answers, I think, in some of the non-operative realms in particular. We've built a huge physiotherapy program. It's taken us 2 years to build, and we'll start there at seeing if some of the, you know, some of the exercises we put into play will help change some of these outcomes. But this data really just doesn't exist. And the type of clinic we've created in terms of supporting patients and supporting their needs really hasn't existed. It's been just a simple discussion of surgery or not surgery. So I'm going to turn over to Nimish with that and give you some more granular insights. We've got our psychology program, et cetera, all embedded within the care pathway.
All right, yeah. I'll first just make a small comment about the imaging that we actually do for these patients. And as you said, Michael, and as Jeff said, you go for like cervical flexion extension MRI. From the patient feedback, what we actually found out is that the bore of the MRI machine is small, and a lot of patients complained that they were not able to get into their highest flexion and extension to be able to document if they had that abnormality or not. So we made a change since then, that we have started, since we are only looking at the angles, which are all based on bony structures, now we do a CT FlexX instead of doing an MRI flexion extension, because that gives us better understanding of the bony landmark-based angle values. So that's a little bit of a change we have made from FlexX MRIs. The other thing for imaging that we do is we have also, there's a lot of debate, and a lot of people go to US and south of the border to get a dynamic fluoroscopic views looking at atlantoaxial views and other things. There's no literature reporting at what's the normal mobility of the atlantoaxial junction or the C1 over C2 lateral overhang in the normal population. Whatever was reported by White and Punjabi was 3 millimeters in the past, but there's a couple of reports that have come out now which say that the normal is 5 millimeters. So we usually do with our radiology colleagues, we've been able to do that, looking at potentially the atlantoaxial instability. And it's quite interesting that I could count those patients on my fingers who actually have had that high mobility. And otherwise, most of the patients who present with headaches actually have like a normal mobility in the range. All the patients that I have seen from headaches and perspective with EDS, where there's a suspicion of instability, I usually am able to categorize them in 3 different buckets. The first bucket is they're actually, Marcus, you it was quite interesting. I liked it when you showed your 4 types of Chiari malformations. So the second type of Chiari malformation, which you showed, which is actually a small Syringomyelia, which lies just below the where the foramen magnum ends. That is what I have found in around 4 or 5 of patients. When those are the patients who have the hypoplastic posterior fossa and have kind of like a mesodermal dysplasia kind of a picture. So that is one group where there's probably a CSF outflow obstruction issue, and I've sent them to Michael recently, a couple of them. The second patient population that I have seen, as I was saying, is the ones which are postulated as atlantoaxial or cranio-cervical instability. So only 2 patients until of the around 94 that we have imaged with dynamic fluoroscopy have actually shown a lateral mass overhang of C1/C2 of around 7 millimeters on each side. So what we did in those patients is because there was, and these were the patients who presented with transient neurological symptoms. So now what we have started doing in those patients who have this abnormal hypermobility, we send them for somatosensory evoked potentials, because that goes with the hypothetical postulate that brainstem stretching is happening, and there's some form of neurological insult which is not manifested in MRI, but probably now we have a couple of cases in which we have those somatosensory evoked potentials that have shown that there's an asymmetry between side to side.
That's interesting. Yeah, Jeff Wilson kind of commented on the use of high resolution microstructural MRI as a further advance. So, you know, there isn't really a lot of literature on the use of that in these types of disorders, but those techniques are becoming much more practical, so that might be an opportunity. Marcus, have you had any experience with the use of microstructural MRI in some of the patients you've treated?
No, we haven't done that. I was going to just comment about the flexion extension CT. I agree with Nimish that that's what we do. I showed in my cases that we did that, but we don't do rotation. I know that for some people who do this surgery, they rely a lot on the rotation measurements. And our view is that that's not, the normal ranges are not well established, and it's not of value. It's the flexion extension values. I was interested to hear about the somatosensory back potentials. I think that's something we'll be doing more of.
Yeah, I think certainly I think potentially looking at physiology or the imaging would be very helpful. In the end, I think the challenge will be to correlate objective validated imaging with objective neurological or neurophysiological issues. Albert, did you want to maybe handle one more question from the audience, and then maybe
sure. It's probably a bit of a follow-up as well, and I think Marcus sort of alluded to it in terms of looking simply at sort of imaging parameters and which parameters are considered sort of important. And so just because one particular value is abnormal may or may not necessarily correlate with symptoms, and you have to sort of look at the constellation. I guess the other piece of that then, if you are suspicious that there may be a parameter that's abnormal, and you're thinking about whether or not you may sort of guide in terms of considering a stabilization. What about non-operative trials like splinting, bracing? Does that improve symptoms? Have any of you found that sort of helpful in your practices?
Yep. So, and I was coming to back to that. Sorry, it took a little while. Is that the first group of patients that I've seen is the one which have smaller Chiari, 3 or 4 patients. Second group of patients which have atlantoaxial. But the biggest group of patients that I've had, we are presenting with headaches, or as you say, the transient neurological symptoms of the cervicomedullary syndrome. But their imaging is pretty clean. Their imaging potentials are normal. However, that is the group which we have seen have coexistent postural or orthostatic tachycardia syndrome. And alluding back to what Marcus is saying, I think understanding the CSF physiology is quite complex. There's a lot of changes which happen in cerebral autoregulation, which correlate with cardiovascular changes when you change your position from standing to sitting. The effect of baroreceptors, how they control the sympathetic pathways or the parasympathetic pathways to regulate the arterial flow, the venous flow, and the CSF flow. So my understanding, majority of the patients that we see have that autonomic dysfunction where the homeostatic symptom of the sympathetic and parasympathetic discharge is not contributing enough and is causing abnormal cerebral perfusion pressure or the intracranial pressure, which is responsible for their symptoms, but essentially there's no structural abnormality. And to that effect, bracing really helps because bracing increases, like there's been reports and literature is like clearly reported, bracing increases the intracranial pressure by approximately 5 to 15 millimeters of mercury. So these patients are the ones who present with symptoms of spontaneous intracranial hypotension, but there's no dural leak. It's just an autonomic dysfunction which is happening secondary to aberrant sympathetic outflow. So bracing obviously helps with them. We are right now developing a cranio-cervical instability rehabilitation program where we will look at structured exercise regime in conjunction with a cardiovascular regime to see if we can kind of like desensitize that sympathetic nervous system and kind of come up with a protocol to help them with the headaches. In short, like that is the best we have right now. There's no structured rehab protocols for this, but we are trying to develop it based on both cardiovascular and cerebrovascular perfusion. We have a team of kinesiology and physical education who works with this, and we have our cardiac rehab scientists who work with it on that.
Okay, thank you. So I think just in view of the time, and look, we could spend all evening on this, obviously. This is just to, I think, to kind of to introduce the subject, but clearly there's a lot to be learned, and this requires, I think, a multidisciplinary approach. We need evidence and needs to be prospectively, accrued. There is the expertise to handle this in Toronto for sure. I think it's a question of now trying to direct this, and I think that one of the opportunities that we would have is to kind of perhaps formalize the collaboration between the University of Toronto Spine program and the Ehlers Danlos clinic, and perhaps that could be one of the next steps, and then we could then, carry forward these discussion points. So I want to just thank all of the panelists, our two speakers, for an excellent discussion, and we'll look forward to next steps. And I think we'll now close out the symposium with a little acknowledgement to Dr. Stoodley and a little award presentations.
I also wanted to, echo those sentiments, and I recognize this is a great opportunity for our citywide program to interface with experts within the field and really to bring the patient-centered focus of this. I know, there have been a few participants on the line that have various conditions similar to what we have sort of discussed, and even sort of going through some of the Q&As, there's questions in terms of interpretation of some imaging findings, what they mean, and obviously looking towards solutions for symptoms that are present.
Okay, so Nadia, do we have an image of what we're going to be sending Dr. Stoodley? Otherwise we can...
No, unfortunately we don't, but I can promise you it's very, very beautiful.
Okay. So there'll be a plaque and a certificate, an honorarium, as well as the coveted University of Toronto Department of Surgery tie,
yes.
Which now interestingly in the COVID era, none of us are wearing ties. It'll be interesting to see what evolves, but we're very grateful for your excellent lectures, for your participation, and your work isn't done yet. So ladies and gentlemen, we're very pleased that we've had excellent participation. We've had over 200 people at some point participating. this evening's webinar, very active question and answer session. So we're going to wrap things up this evening. Please join us tomorrow at 5 o'clock for the second part of our SpineFest. And tomorrow will be focused on the trainees. So we have several of our outstanding residents and research fellows who will be presenting their work. We'll have an e-poster session. And then in the evening, we will have an acknowledgement and an expression of gratitude for our graduating fellows. Albert, final words over to you.
Yes, so thank you so much, everyone, for really participating in our sort of inaugural virtual SpineFest this year. And you know, I think like many other aspects of life that has arisen over the last couple of months, really look towards everybody sort of supporting each other through this period of time. I just want to acknowledge and thank all the panelists for all their time and valued inputs, and it's really great to see the program continuing to grow. You know, I look forward to more formally celebrating the graduating fellows tomorrow evening. Many thanks again to the University Department of Surgery, the divisions of orthopedics and neurosurgery, as well as our industry sponsors for their tremendous support over many years.
Thank you, everyone. Have a good evening, and Dr. Stoodley, have a good rest of the day. Take care, everyone. See you tomorrow evening. Bye-bye.